The Ottawa Charter offered a bold idea. Governments, institutions, and everyday people could shape health not just through medicine, but through policy, environment, education, and empowerment. Nearly 4 decades later, its message is more urgent than ever, and yet it remains ignored. Let's change that. From PHI Media, I'm Gordon Thane, and in this episode, we'll unpack the Ottawa Charter for Health Promotion, from its signage in Ottawa, Ontario, exploring what sparked it, why it felt so revolutionary at the time, how it slipped from practice, and why its vision still matters today. Because if we already had the blueprint for a healthier society, why didn't we build it?
The WHO says contagious afflictions such as HIV/AIDS and tuberculosis are not the ones that pose the greatest global threat to public health. Instead, it says the major threat comes from non-communicable diseases, or NCDs.
Let's rewind to the 1970s and ask, what was missing from public health? In 1978, the Alma Ata Declaration called for health for all, yet health systems remained focused on hospitals and treatments. Meanwhile, chronic diseases like heart disease, diabetes, cancer surged through the early 1980s.
Cardiovascular disease kills more than 17 million people every year. It's the world's leading cause of death.
The World Health Organization's Cancer Agency have issued a dire warning about the staggering rise in new cancer cases. By 2050, the number is projected to soar to over 35 million, a shocking 77% increase from 2022.
The number of adults living with diabetes worldwide will more than double by 2050, surpassing most diseases on a global scale. That's according to a study published in the Lancet Journal. The research reveals that more than 500 million people currently live with diabetes worldwide, and every country is expected to witness a major increase.
Against spiraling costs and growing illness, one Canadian minister tried something radical. Enter Marc Lalonde. In 1974, Health Minister Marc Lalonde introduced a report that reframed health around 4 pillars: environment, behavior, biology, and healthcare. He framed health as a state of mind as well as body. His insight echoed globally, but lacked a unified strategy. Several initiatives were emerging across the globe, but yet still felt a bit isolated. Hospitals continued to overflow, budgets ballooned, and inequities deepened. Those sparks weren't enough, until November 1986. During the closing session on November 21, 1986, at the first International Conference on Health Promotion, there was a declaration. The event was co-hosted by the WHO, Health and Welfare Canada, and the Canadian Public Health Association, drawing over 200 participants from 38 countries, including clinicians, community leaders, politicians, and NGOs. It was a direct response to growing calls for a new public health movement, inspired by the 1978 Alma Ata Declaration on Primary Healthcare, the WHO document Targets for Health for All, and recent World Health Assembly debates on intersectoral action for health. Although many discussions centered on challenges of industrialized nations, delegates consciously linked those issues to similar concerns in low and middle income regions. The charter they drafted reflected a shared and very personal commitment to put health on the agenda of policymakers in all sectors, to close the health gap within and between societies, and to view health maintenance as both a social investment and a pressing moral challenge. Before we start unpacking each layer, it's helpful to know how the Ottawa Charter is actually structured. It's not a massive document, barely 5 pages long, but each word packs a punch. It starts off with a declaration. This is the Charter's opening commitment. Their aim? To chart a global course towards health for all by the year 2000. Then they go into definitions. Here's where the Charter drops one of its most quoted lines. It defines health promotion as a process of enabling people to increase control over and to improve their health. Not a program, not a poster campaign, a process, focused on power, agency, and structural conditions. Next up is the prerequisites for health. There are 9 of them: peace, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and equity. If these sound familiar to you, it's because they're closely aligned to what we now call the social determinants of health. Next are the core strategies. 3 verbs: advocate, enable, and mediate. The Charter wraps up with perhaps the most important component: the action areas. There are 5 of them. These are all practical steps, and they all connect back to the strategies. One of the key concepts to put all this together is the definition of health, which is described as a resource for everyday life, not the objective of living. It's a positive concept emphasizing social and personal resources as well as physical capacities, while health promotion is a process of enabling people to increase control over and to improve their health. Unlike healthcare, which largely operates under the medical model of health, diagnosing and treating diseases once they appear, health promotion, on the other hand, seeks to prevent illness and create conditions for well-being. If healthcare is the ambulance waiting at the bottom of a cliff, health promotion can be seen as the guardrail that's at the top, and maybe even the well-lit sign that warns you that there's danger ahead in the first place. That shift from repair to design was revolutionary in 1986 and still challenges the systems that invest 90% of resources in downstream treatment and only a fraction in upstream prevention. If you're someone that learns visually, picture the Ottawa Charter as a diagram or a logo that's still being used today. Imagine a bold red circle. This represents building healthy public policy, and it's a structure that holds everything together. Inside that circle is a central spot symbolizing the core strategies, and there's 3 of them: enable, mediate, and advocate. Advocate means championing the political, economic, and social conditions that make health possible. From lobbying for a living wage to defending green space zoning at City Council, think of it as the Charter's public megaphone. Enable is about equity, ensuring every person, regardless of income, gender, or location, has the skills, resources, and opportunities to achieve their fullest health potential. It's why interventions must be accessible to the most marginalized, not just the already well. Mediate recognizes that health rarely sits in one ministry or one sector. It's the art of brokering agreements between governments, NGOs, businesses, and communities, aligning agendas so that a transportation plan, for instance, also advances wellness and equity. From that spot rises 3 wings. The top wing, which actually breaks the circle, reflects strengthened community action and developing personal skills. The right wing symbolizes create supportive environments. The bottom wing represents reorienting health services. Each wing carries the energy of the Ottawa Charter outward. The structure shows that while policy holds the system, strategy fuels it, and action areas deliver the change. When you put it all together, advocate gives the voice, enable gives the means, and mediate builds the bridges. Together they turn lofty ideas into coordinated action. These strategies are the method, the how through which health promotion happens, and they power the 5 action areas, the what, of the Ottawa Charter. The first, build healthy public policy. Put health on the agenda of policymakers in every sector. Legislation, taxation, and organizational change all contribute to this. Creating supportive environments. Foster the environments that are safe, stimulating, satisfying, and enjoyable. This includes our natural and built environments. Strengthen community action. Empowering communities to set priorities, make decisions, and implement change. 4. Develop personal skills. Provide education and information that enhances life skills, decision-making, and resilience. Number 5. Reorient health services. Shift the focus of health services from curative care toward prevention and promotion. Together, these strategies and actions offer a comprehensive approach, one that's as relevant today as it was in 1986. One name that we can't forget in all of this, and one name that you'll see coming up very often in the global health, public health, and health promotion space, is Dr. Ilona Kickbush, a political scientist and one of the architects of the Charter, helped lead WHO's health promotion programs through the 1980s, and her work laid the foundation for global movements on health equity, healthy cities, and later, health in all policies. I mention her not just for her role in the Charter, but what she represents. Someone who made health political, social, and actionable. It hasn't all been roses and sunshine. Even during the 1986 conference, skeptics were worried that the Charter's early rollout leaned too heavily on lifestyle campaigns and disease-specific targets. Stop smoking, eat better, move more, without equally bold economic or environmental reforms. A 1987 WHO follow-up report noted that countries were quick to launch behavior change programs, but slow to tackle underlying issues like urban poverty or housing shortages. 2 decades later, WHO's milestone in health promotion document echoed that critique. Real progress required structural change, living wages, safe transit, affordable food, not just slogans. Why keep this in mind? If we present the Charter as a silver bullet, we risk overlooking its own learning curve. Health promotion must marry individual empowerment with systemic levers. WHO's Ilona Kickbush called the Charter empowerment at its core. The Healthy Cities Project was born that same year. Kickbush's pilot initiative started with 11 European cities. Today, more than 900 cities worldwide apply Charter principles locally. Those breakthroughs felt tectonic on paper, especially when politics and budgets pulled the other way. In the late 1980s and early 90s, social programs were cut, public health budgets slashed, and the Charter lost momentum. Health Promotion International later noted that without clear implementation tools or enforcement mechanisms, the Charter's influence faded, especially around reorienting health services. Though there were some that kept this flame alive. Finland proved the model in Europe, halfway around the globe. In North Karelia, Finland, doctors worked with farmers, shopkeepers, and schools to reduce smoking and cholesterol. From 1972 to 2014, cardiovascular mortality dropped by 80%. But examples like this were considered outliers. Elsewhere, public health units were defunded, school lunches cut. Researchers warned of new distractions, innovative hype without infrastructure, overuse of the word resilience, and confusing education campaigns with genuine policy reform. History could have ended there. The Charter shelved and forgotten. But it didn't. The Charter lived on through global declarations. The Jakarta Declaration in 1997 stressed intersectoral partnerships and community capacity. The Bangkok Charter of 2005 focused on globalization and corporate accountability. Health in All Policies, or HIAP, became a practical way to realize the Charter. The Adelaide Statement of 2010 called Health in All Policies a new social contract. The Helsinki Framework of 2013 offered a roadmap for governments to adopt it nationally. So what does health in all policies look like on the street? Adelaide is planting 3 million urban trees to cool neighborhoods and improve mental health. Barcelona expanded its bike lanes based on health impact projections, lowering emissions and saving lives. Technology can widen gaps, but people-centered experiments like social prescribing show how to keep equity at the core. In the UK, doctors now prescribe community gardens or art classes, cutting loneliness and clinic visits. Meanwhile, a 2023 review warns that digital health and AI, if not equity-centered, risk reinforcing old disparities. Legal scholars are now even asking the question, can the Charter's prerequisites like food, shelter, education become enforceable rights under the constitutional law? Imagine a city where every budget, transit, housing, climate is judged by its health impact. That's the Ottawa Charter, alive in motion. This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art designed for our show by LaShawn Benedict. The Public Health Insight Podcast is produced by PHI Media. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.